All right, let's build a solid clinical framework for a topic you're absolutely going to see: benign tumors and those tricky tumor-like lesions of the musculoskeletal system. Let's jump right in.
So here's the classic situation, right? You get an x-ray for one thing, and boom, there it is, a lesion in the bone found completely by chance, an incidentaloma. This happens all the time, and you need a structured, systematic way to think about it to make sure you do the right thing. So how do we tackle this? What's the game plan? That's exactly what we're going to break down right now.
The foundation for all of this, the language that we all speak in orthopedic oncology, is the Enchondroma system. You really have to have a solid grip on this because it's how we stage tumors and ultimately how we plan our treatments.
So what is it? Well, the GTM system looks at three key things. G stands for histologic grade, basically how aggressive the cells look under a microscope. T is for the local tumor site or its size, and M is for metastasis, has it spread? For this discussion, we are zeroing in on just one category, G0, which means benign tumors.
But here's the thing, not all benign lesions are created equal. Not by a long shot. The Enchondroma system is smart, and it breaks down these G0 tumors even further, based on how they're behaving. Is it just sitting there doing nothing? Is it growing? Or is it actually getting aggressive and destructive? Making this distinction is absolutely crucial. So we've got three stages to think about. Stage 1 is inactive. Think of it as latent, it's just chilling, contained within a nice, neat capsule. Then you have stage 2, which is active. This means, okay, it's growing, but it's still contained. And finally, you have stage 3, aggressive. Now, this is where things get a bit more serious. The lesion is growing, it's pushing boundaries, and it can be locally destructive, even though it's still technically benign and won't metastasize. So you might be asking, why does all this staging matter so much? Well, it's simple. The stage tells us exactly what to do. The whole goal here is to match our surgical plan to the biological personality of the tumor. You don't want to undertreat something that's aggressive, but you also don't want to overtreat something that's totally harmless. This table lays it all out perfectly. Look at stage 1, the inactive lesion. A lot of the time, we can just observe it, or maybe we do a simple intralesional excision. Basically, we just scoop it out. Now, when we get to stage 2, the active lesion, we need to be a bit more thorough. We might do a marginal excision, or if we scoop it out, we'll use an adjuvant, that's something like phenol or liquid nitrogen, to kill any leftover cells. And for those stage 3 aggressive lesions, we have to get a clean margin. That means a marginal or even a wide excision to make sure it doesn't come back. You know, context is everything here. With these benign G0 lesions, our main goal, our prime directive, is to preserve function. We take out the lesion, sure, but we want to keep the patient's limb working as perfectly as possible. This is a completely different world from treating malignant tumors, where the #1 priority is getting the entire cancer out, even if it means sacrificing function. So you can see why getting that G0 staging right is so critical. It guides the entire surgical philosophy. Okay, we've got the framework down. Now let's put some names to these concepts. What are some of the actual benign tumors you're going to run into? So here are some of the usual suspects. You've got your bone formers like osteoma and osteoid osteoma. You have cartilage-forming tumors like enchondroma and the super common osteochondroma. And then there's a really important one, giant cell tumor of bone. This is a classic example of a lesion that, while benign, is often locally aggressive, frequently putting it squarely in that stage 3 category. All right, now for a really important distinction. A heads up, really. Not everything that looks like a tumor on an X-ray is a tumor. There's this whole other category of what we call tumor-like lesions that you have to keep in your differential diagnosis. On this list, you'll find things like a solitary bone cyst, which is pretty much just a fluid-filled hole in the bone. Then there's its more dramatic cousin, the aneurysmal bone cyst, a big, blood-filled, expansile lesion. We also have developmental things like fibrous dysplasia. The key thing to remember is, even though these aren't cancers, they can still cause big problems like pain or fractures, so we manage them using that very same clinical framework. Okay, let's wrap this up. I want to boil everything down to the most important high-yield messages. This is the stuff you absolutely need to know for your rotations and, of course, for your board exams. So here it is, the big takeaways. #1, benign lesions are G0 in the Enchondroma system. #2, we stage them as 1, 2, or 3 based on how they're behaving. 3, that stage tells you exactly what surgery to do. It's a direct link. And finally, #4, always remember to think about those tumor-like mimics in your differential. And I'll leave you with this to chew on. We've laid out all these principles, right? But how do they actually play out in the messy, complex real world? How does treating an active lesion in a 10-year-old's femur right next to a growth plate change things compared to treating that same lesion in a 40-year-old's collarbone? That is where the art of medicine really comes in, blending this foundational knowledge with true clinical judgment.